Bismillahirrahmanirrahim. The inflammatory disorders of the panniculus or the hypodermis is termed as panniculitis, and the plural for this term is panniculitides. Following are the references for this video. The function of the subcutaneous tissue, that is also termed as subcutis or hypodermis, are thermal regulation, insulation, provision of energy, and protection from mechanical injuries. They are composed of lobules of mature adipose tissue, and these adipocytes individually are round and rich in cytoplasmic lipids. They are positive for S100 protein and vimentin on immunohistochemistry, while these lobules are separated by fibrous septae. Two important conditions of this panniculitis are septal panniculitis and lobular panniculitis. The septal variety, one example is Erythema nodosum, while the example for lobular panniculitis is panniculitis that is associated with pancreatitis. So the two types of panniculitis, common types, are Erythema nodosum and Erythema induratum. The most common among these is Erythema nodosum. While there are many other types of panniculitis are present, these are Weber-Christian disease, factitial panniculitis, rare type of T-cell lymphoma, and systemic lupus erythematosus. The panniculitis are diseases where the major focus of inflammation is in the subcutaneous tissue. So this is a diverse group of diseases that are characterized by inflammation that is present mainly in the subcutis. The lesion initially is erythematous or violaceous nodule. It may be tender or non-tender, ulcerate or heal without scarring, and it may be soft or hard on palpation.
As we have seen in the histology of the hypodermis is composed of lobules of the adipocytes, and these are separated by fibrous septae. When this inflammation is limited to fibrous septae, this is termed as septal panniculitis, and when this inflammation mostly involves the lobule of the fat, it is termed as lobular panniculitis. This is the lesion that is the lesion of erythema nodosum. Uh, the details of these lesions we are going to see later in detail. So this panniculitis manifests itself as erythema nodosum or erythema induratum. This is the classification scheme for the panniculitis. The lobular or septal panniculitis can be due to neonatal physical, can be due to drugs, idiopathic reasons, infections, cancers, other systemic disease, vasculitis, or metabolic deficiencies. Erythema nodosum is a non-suppurative, self-limited, poorly defined, exquisitely tender erythematous plaque and nodule that may be more readily palpated than seen. They can be due to infections such as beta hemolytic streptococcal infection or tuberculosis or coccidioidomycosis or histoplasmosis or leprosy. The streptococci and tuberculosis are common, while these leprosy, histoplasmosis, and coccidioidomycosis infections are uncommon. Drugs such as sulfonamide and oral contraceptives are also associated with erythema nodosum. Systemic disorders such as sarcoidosis and inflammatory bowel disease are also associated with erythema nodosum. Malignant neoplasm are also associated with this condition. and about 50% of the cases are considered idiopathic, or some people suggest that it is a delayed hypersensitivity reaction. There is an antigen that is responsible for the cutaneous lesion, fever, and malaise, and within days it flattens and results in bruise-like lesion and heals without scarring. It is more common in females are about thrice commonly affected by this condition, and usually they are in their third decade of the life. This is a more detailed list of causes of erythema nodosum. This condition is associated with bacterial, fungal, viral, and parasitic infections. Also, there are drugs responsible: sulfonamides, bromides, iodides, oral contraceptive, minocycline, cold salt, penicillin, and salicylates. All are uh, the causes of erythema nodosum. Hodgkin and non-Hodgkin lymphoma, leukemia, and renal cell carcinoma are also considered as cause of erythema nodosum, and other causes are sarcoidosis, inflammatory bowel disease, ulcerative colitis, and Crohn's disease both, and Beckett's disease. So the lesion of the erythema nodosum is a dome-shaped tender to erythematous nodule that ranges between 3 to 20 centimeter in size, and the anterior aspect of the leg are commonly affected, as is seen in this picture. The margins are not sharp, and this distribution is bilateral and asymmetric. Grossly, they look like erythema, but on palpation, they feel like a nodule. These lesions are accompanied by fever, malaise, and arthralgia, especially the ankle joint, in 50% of the cases. As the time goes on, they become firm and less tender, and within 3 to 6 weeks, these lesions disappear and heal without scar formation. Lesions are oval, round, archiform, or they change their color. As they age, they become violaceous, brown, yellow, green. They change the color like a resolving hematoma. This is the lesion of erythema nodosum, the elevated central tender nodule, and it is surrounded by zone of erythema. Such lesion may reach up to several centimeters in size over week or month. The morphology of erythema nodosum is variable depending on the age of the lesion. Early lesions show that there is connective tissue septa widening due to edema, fibrin exudation, and infiltration by the neutrophils, while late lesions show infiltration by lymphocytes, histiocytes, and multinucleated giant cells. There are occasionally eosinophils also present with septal fibrosis. Cells extend into the lobule from the interface between the septum and the fat lobule. Vasculitis is not present in erythema nodosum. These photomicrographs are showing the histopathological appearance of the late lesion of erythema nodosum. Here, it is clearly evident that the hypodermis or subcutis is involved, and there is extensive inflammation with presence of multinuclear giant cell and fibrosis of the septum that is separating with these fat lobules. Also, there is involvement of the subcutaneous fat only. The epidermis is unremarkable. The diagnosis of erythema nodosum is made on clinical criteria and biopsy. The blood picture shows increased ESR, leukocytosis, and C-reactive protein. The culture of the throat, uh, you may get group A beta hemolytic streptococci, or stool may give you clue to Yersinia infection. The chest X-ray and gallium scan are helpful to rule out sarcoidosis. The lesion heals in 6 weeks without scar formation, and the lesion of erythema nodosum never ulcerate. It should be diagnosed, differentially diagnosed from other forms of panniculitis, panarteritis nodosa, nodular vasculitis, peritibial myxedema, non-ulcerated gumma, and lymphoma. The treatment for erythema nodosum is symptomatic, such as bed rest, compressive bandages of the lower leg, and wet dressing, while anti-inflammatory such as salicylates, non-steroidal anti-inflammatory drugs, and systemic glucocorticoids are also helpful. The systemic glucocorticoid use is limited only to known etiology, and infection should be excluded before its use. Now, erythema induratum. Erythema induratum primarily affect adolescents and menopausal women. The cause is unknown, but it is considered that it is associated with Mycobacterium tuberculosis infection. To some people, the primary cause is compromise of the one of the main blood vessel. That compromise or that blockage results in fat necrosis and inflammation. Morphologically, there is erythematosus, slightly tender nodule that usually goes on to ulcerate. There is chronic recurrent subcutaneous nodule of or plaque on the legs, especially calves. The treatment is use of systemic glucocorticoids. On morphology, the lesion of erythema induratum show granulomatous inflammation and zone of caseous necrosis that involve the fat lobule. The early lesions show necrotizing vasculitis affecting a small to medium-sized arteries and vein in the deep dermis and subcutis. There is endothelial swelling that may progress to thrombus formation and fibrous thickening of the intima, and these lesions can also be termed sometimes as nodular vasculitis. Ultimately, the lesion may ulcerate, and finally it it heals with fibrosis. One condition of panniculitis is due to pancreatic diseases, and this is termed is pancreatic panniculitis. It is a disease of middle-aged to elderly individual and more common in male, and the lesion is painful erythematous nodule and plaque that may fluctuate and occur. These may occur at any site with the predilection for abdomen, buttock, and legs. They are associated with arthritis and polycirrhosis and pancreatitis or pancreatic carcinoma. They are associated with alcoholism, abdominal pain, weight loss, or recent onset diabetes mellitus. On, on morphology, they exhibit the features of lobular panniculitis or erythema induratum. On examination, there may be presence of pleural effusion, ascites, and arthritis, particularly of ankle, and laboratory examinations show eosinophilia, hyperlipasemia, hyperamylasemia, and increased excretion of amylase and or lipase in the urine. They are considered to be due to breakdown of subcutaneous fat that is caused by pancreatic enzymes that are released into the circulation. And the treatment is the uh, treatment of underlying cause. So this gross picture is showing the lesions of pancreatic panniculitis. There are multiple erythematous painful nodules and plaques present, and uh, these lesions fluctuate, and these are present in the lower extremity, but similar lesions are also found on the trunk and on the buttocks. The lesion of alpha-1 antitrypsin deficiency panniculitis is a recurrent tender erythematous subcutaneous nodule that ranges from 1 to 5 centimeter in size, and they are present on the trunk and proximal extremities. The nodule break down and discharge a clear serous or oily fluid, and diagnosis is made by decreased serum alpha-1 antitrypsin enzyme, and treatment is oral dapsone in doses up to 200 milligram per day. There are very rare forms of panniculitis. One is Weber-Christian disease, that is relapsing febrile nodular panniculitis. This is a rare form of lobular non-vasculitic panniculitis that is seen in children and adults. There are crops of erythematous plaque or nodules, and these are predominantly present on the lower extremities. These are created by deep-seated foci of inflammation that contain aggregates of foamy macrophages that are mixed with lymphocyte, neutrophils, and giant cells. Factitious panniculitis is a secondary panniculitis, and it is due to self-inflicted trauma or injection of foreign or toxic substances into the subcutis. T-cell lymphoma, uh, home to the fat lobules, produce fat necrosis and superimposed inflammation that mimic panniculitis. Systemic lupus erythematosus is also associated occasionally with inflammation, and this inflammation is present in the subcutis and associated panniculitis.